We're recording. I'd like to welcome everybody to today's webinar. The topic is mental health services, provision or referral. And this is Mercedes Byrne Klug speaking for the University of Iowa School of Social Work. I want to make sure everybody knows that the handout of today's presentation is on the nursing home social work resource page. If anybody would like that, and also the full bio for our speaker today, Dr. Pat Gleason-Wynn, is also on the website, and then the objectives and overview that Dr. Gleason-Wynn has prepared also there. So welcome. At the very end, we'll have about 10 minutes for questions. If you're calling in the webinar by phone, I will unmute you for the question and answer period. Those of you who are listening through the computer, please feel free to type something in the chat box if you have a question for Dr. Gleason-Wynn. Okay. Welcome, everybody. Hope it's spring. I think today is the official first day of spring. And also welcome to the Mental Health Services Provision or Referral webinar. Next slide, please. Speaker today is Dr. Pat Gleason-Wynn. She received her PhD from the University of Texas at Arlington, and she has a wealth of experience working with older adults and teaching social work students about working with older adults. She has direct clinical practice in nursing homes, in outpatient clinic settings, and also in hospice. So she's a specialist in gerontological social work and also palliative care. She is an expert trainer for the Council on Social Work Education in their Gero Ed Center. So she goes around the country and speaks with social work students about working with older adults and issues that affect older adults. She's currently a co-chair of her county's United Way, the Health Council of the United Way in her county, and also past president of the Texas chapter of the National Association of Social Workers. She's currently employed at Harris Methodist, Fort Worth, Texas, and in Odyssey Hospice, also in Fort Worth. Next slide. So just a reminder, on the website, the Nursing Home Social Resource page, we have Pat's full bio. I just gave a little abbreviation online. Then also the objectives that Dr. Gleason-Wynn has prepared for today's session, the PowerPoint from today, and then this session is being recorded right now, and so later this afternoon I will also post the recording of today's session in case you want to let any of your colleagues know that it's available. All right, let's switch over to the tab that says Mental Health, and Pat, take it away.
Thank you, and welcome to everyone that's online and listening on the computer and on the phone. This is leading. As Mercedes said, I'm going to be talking about mental health services or referral. But before I get started, I just want to wish all of you a happy Professional Social Work Month. As you know, instead every year we celebrate, or social workers celebrate Social Work Month, and I think it's adequate that we have a whole month for social workers because we do so many great things. So I appreciate being part of your Social Work Month, this presentation. Over the next 45 minutes, I plan to address the following objectives. It's my goal that by the end of this presentation that you will have gained knowledge of mental health concerns for residents in long-term care. You gain insight into the challenges and barriers in the provision or referral of mental health care. And then you also the role and the task of social workers in addressing mental health needs. And finally, to gain knowledge of resources available to assist in the assessment and provision of mental health care. How is health defined? According to the Surgeon General's definition, mental health is a reflection of one's psychological well-being and ability to contribute intellectually to functions of daily living, regardless of her or his physical health disability. health is important for personal well-being, for family and interpersonal relationships, and contribution to society or community. The value of good mental health is often overlooked until problems arise. Everyone people on this webinar from all around the United States, and I think it's nice to say there is a large cross-state variation in the rates of mental illness in nursing homes. But one statistic that states that mental illness is the primary diagnosis in 70 to 80% of people living in a nursing home. Another statistic estimates that over 500,000 people with mental illness, and that's not including dementia, reside in nursing homes daily. In 2005, one study using data from the review of MDS data found approximately 1.1 million new admissions in the entire United States. 2.7% indicated schizophrenia, bipolar disorder as a diagnosis. 27.4% indicated schizophrenia, bipolar, depression, or anxiety. Combined, all of these together accounted for approximately 350,000 people of 1.1 million new admissions to the United States nursing homes in 2005 with mental health diagnoses. We know and we've read that older adults have the highest rate of suicide. The highest rate is among people 85 and older. The second highest rate is 75 to 84. Then for people age 65 and older, there is one successful suicide in 4 attempts. And people have often said to me, suicide can happen in nursing homes, but as many of you on this line know and have read, yes, it does happen in nursing homes. So it's something that we, nursing home social should always be aware and cognizant of. Mental health in long-term care facilities is like the proverbial elephant in the living room. We know it exists, but it is routinely unrecognized, undiagnosed, and undertreated. Psychotherapy treatment may not be openly embraced by the resident, the family, or the staff, and I need to add in there even the physician care for our residents. In addition, psychotherapy treatment may not be readily available. In addition, there may be a bias towards using medications to treat people with depression or mental illness rather than psychotherapy or a combination of psychotherapy and medication. And we know that the combination of psychotherapy and antidepressants is very effective among our adult population. On the other side, there may be bias to not do anything because of the attitude or myth that says, "Father, he's old, it won't matter." I know I've encountered that statement a couple of times from physicians, and by your tongue sometimes, or in other times you explain to the physician why it does matter, and hopefully he or she comes along and will agree to you and the other staff take care of the mental health needs of the resident in your facility. Poor health diagnosis in county nursing facilities includes depression, anxiety, loss, substance use, schizophrenia, and personality disorders. When medical problems are accompanied by depression or mental health problems, older adults make more visits to primary physicians, they use more medications, and they're more likely to admit to an emergency room or a hospital. Can slow down recovery, can make pain worse, increase suicide risk, and cause caregiver stress. For instance, you notice in your Medicare or your rehab wings, person suffering from depression, you may see a slowdown in that person's rehab capability or rehab progress, and it does increase the recovery, especially if a person is recovering from hip fracture or a heart attack, if depression is combined with this. the challenges to the provision of care, I think we have numerous challenges in our provision of care for mental illness. But overall, first and foremost, the individual with mental illness is sometimes and often able to seek help or doesn't know how to seek help. Or, as we often say in Texas, they just want to pick themselves up by the bootstraps and get on with it because that's how they think it's supposed to be. Until recently, Medicare has not paid for outpatient mental health services as it did for medical service. Essentially, prior to a couple of years ago, it paid 50% of the cost. As many of you know, that is now changed for 2013. Medicare will pay 80% of its approved amount for the initial visit to a mental health professional to determine the diagnosis and for brief appointments related to managing the medications. But for other appointments, such as therapy, Medicare will pay 65% of its approved amount in 2013. And then the individual or their supplemental insurance policy is responsible for 35%. However, the good news is for many of us in advocating for this is that in 2014, Medicare will pay 80%, just like it does for medically related services. So finally, we're beginning to see that having a broken brain is just as important as having a broken bone. And this has come from years of advocating for this to happen. Oops, I think ahead there. Specifically in nursing home settings, some of the implications or barriers is that we don't have enough trained professionals who understand the aging process and can deliver services to unique nursing facility population. Social workers are the primary providers of psychosocial services in nursing facilities. There is not enough time to address all the needs that are assessed, or lack of skill or experience to address the identified mental needs. These barriers are complicated by weak federal regulations that do not require adequate training or staffing of qualified social workers. We have unrealistic caseloads that has been found and documented in some recent studies. One of these found that the range of caseload is anywhere from 7 to 120 or more residents per social worker. You know that's our ability to meet the needs, and there is poor articulation and definition of social work roles in many of our facilities from state to state. Social worker with a cape here, but as I've alluded, social work is the key player when it comes to identifying residents with poor mental and psychosocial needs. Ideally, the social worker has the responsibility to develop a plan of action. This plan of action is articulated on the care plan and include the direct provision by the social worker of mental care, involvement of other staff such as nursing, activity professional in addressing the needs, and or referral to mental health professionals in the community such as psychiatry, social workers, and psychologists. A couple of slides that I'm going to show you reflect a few chosen competencies and capabilities of all social workers. A more thorough list can be found in the SW standards for social work services in long-term care facilities. It's important to point out, and that I'm aware too, that we all work within a practice level of competency. But these few competencies that I share with you, I believe, are ones that all social workers working in nursing homes have the capability of exhibiting and producing. The first, we all have the competency in conducting a comprehensive evaluation of psychosocial factors that affect older person's physical and mental well-being. Second, we can identify issues that are related to grief and loss, to transitions, and adaptations to changes over the life cycle, so that we can assess cognitive functioning and mental health of older adults, for example, depression and dementia. So, adapt psychosocial educational approach to enhance older persons' capacities and mental health. We can utilize group interventions with older adults and their families, for instance, bereavement groups or reminiscence groups or admission groups in the city. We can support individuals and families dealing with end-of-life issues related to dying, death, losses, and grief. A more complete list of these competencies and capabilities are found in the NHSW standards. I found, though, the length and the experience seems to be key in determining the amount and depth of intervention that each social worker takes. I also think, too, the degree of experience also is reflected in how far one is able to go to make a difference. In other words, how we use our professional self and personal self to help persuade staff to work us as a team. So perhaps the less experienced or confident new social worker may not be as assertive or maybe as confident as a social worker who's been doing this for a number of years. So we may see that difference, but eventually that worker is no longer a new social worker and becomes a very confident and positive, very assertive social worker, again, gaining more experience and doing the job. So that's how competencies can be developed further. I was asked to together to tell you a case study that I had, and this is one of the case studies that I'm very proud of, though it's a convoluted one in a way. As a contract worker, I had a contract with a 60 nursing rural Texas, and I only visited the facility 1 month. So as you can see, the question becomes how to even adequately assess, much less address all the psychosocial in this facility, but you do the best you can, right? I was referred to evaluate an 82-year-old woman. Reported to me that she was not participating in therapy. The staff reported that the patient had dementia and acted depressed. She had behavioral problems, and I put that in quotes, but now she is withdrawn. The staff was very concerned but didn't know what to do. So on my day in the facility, I met with the resident, and luck or fortune would hit, her daughter-in-law was visiting California, making use of all of my resources as family. So I met with the resident and the daughter-in-law to obtain basic social history information. And I met with the resident alone and assessed her mental status and her mood. Her cognitive abilities were fairly well intact, but severely depressed. And this was confirmed by the presence of various symptoms of major depression. She cried throughout my interview with her. She was withdrawn. She didn't want to participate. She had been losing weight, so wasn't eating. She didn't really care how she looked. She wasn't reading her Bible, which was something she enjoyed doing every day. So I saw some of the major symptoms, the clinical symptoms of depression as well. Her history revealed that she had moved to the nursing home about 6 months ago. Shortly after that move, her husband, who was also her roommate, died, and she was moved to another room. And when in this room with a female resident, began to exhibit behavior problems. She, of course, acted out. No one could really define that for me, but acted it out, and she kept crying, and she would holler at the other lady. And probably hindsight, what it is, this probably was a woman suffering from unresolved grief, and no one in the facility could recognize it. And so because they were problems, the staff asked the doctor to put the resident on Haldol. Haldol was never, even though she ceased to be a behavior problem. Well, and what I think is so amazing is that the physician really believed that Haldol was an antidepressant, but I'll say more on that in a minute. The resident became more and more withdrawn and less able to care for herself. During my brief session with her, I was able to show her first off that she wasn't losing her mind, and I think that was the biggest fear for her, and that there was hope. I believe reassurance and support of the resident is very positive thing to do. But reassurance and recommendations for suggested treatment were also given to the daughter-in-law. Given I was the contract social worker and I was only there once a month, I had to assist other staff to help with the intervention plan, including and activities. First, I suggested that the director to contact the physician and discontinue the Haldol, and suggested that he start her on an antidepressant. As you know, as a social worker, we can't prescribe medications, but we certainly can make strong suggestions. The doctor was unwilling to take her off the Haldol. He was unwilling to start her on the antidepressant. So what any good social worker would do, I suggested that the daughter-in-law go down to his office and wait to see him. Small town communities, you can do these kind of things. So she went down and she sat in the office until he was done with all his pay for the day, and he ended up stopping the Haldol, though he was still insistent that it was an antidepressant. But he refused to start an antidepressant. He didn't think that this was necessary for an old person, is what he said. Daughter-in-law kicked in and did that, and then I enforced of my assessment, obviously with the resident's permission, and then I told them how I thought they could work with her behaviorally to make a difference, getting her dressed in street clothes, acknowledging the loss of her husband, mentioning his name and talking about him, just so that she would see that it was forgotten that he was somebody significant in her life and that she truly missed him, and to invite her to activities. Long story short, the staff did continue to offer reassurance and offer hope. I saw her 2 more times before she moved out to California to live in an assisted living facility. She moved out with her son and daughter-in-law, and the nursing home reported to me that she was out riding a stationary bike, and she was doing quite well. So that's a happy ending story. And but it just demonstrates how it takes not just a social worker, but all of our abilities, resources, knowledge, skills, creativity to address an example of mental health needs of our residents in the nursing home. I firmly believe, too, that sometimes angels are sitting on our shoulders as social workers, so I probably helped as well. But this case study reflect the steps that are required to address mental health needs. First, assessment. Very thorough assessment is needed to determine and guide our plan of action. I firmly believe we need to place on our residents in the nursing home and to look at them and to ask them questions and look at their mood, look at their behaviors, check their cognitive abilities. Paper and pen assessment tools, such as we have in our MDS 3.0, are good adjuncts helping us document signs and symptoms. But keep in mind that these tools may not always pick up subtleties of our working with resident. What the body's saying versus the verbal comments. We're able to notice incongruence. frequencies, what people are telling versus what the body might be saying. So laying eyes on the resident, looking at them, does supplement and complement our assessment tools. So y'all are working in a nursing home, so you're familiar with the following assessment tools that are embedded in the MDS 3.0. The first one being the BIMS, which is the brief interview for mental assessment, and that's section C, and that takes a look at cognitive patterns, and that's used to determine individuals' attention, orientation, and ability to register and to recall new information. The PHQ-9 is a patient health questionnaire, and this part that we are doing in section D is a print module that comes out of a self-administered version of what's called a Prime-MD diagnostic instrument for common mental disorders. So we just do the PHQ-9, which is the depression module in the 3.0. Then the CAM, which is confusion assessment, and that looks at signs and symptoms of delirium. So that's of our assessment tool. Those are our assessment tools in addition to our face-to-face, lay eyes on assessment of the resident. Another approach or additional approach is to refer. Oh, sorry, got skipping it here. This I've talked next because from the assessment we develop our plan, which is our approaches to care. So services, I'm going to start out first, is that services are provided directly by the social worker, by us. The goal here is to prevent development and worsening of poor mental health, addressing perhaps milder conditions such as adjustment, loss, motivation. Social workers can provide or coordinate. We can do screening, the referral. We can work with the disciplinary staff to target symptoms. We can assess outcomes, especially if pharmacotherapy is used as an option as well. Is medication working? Does it make a difference? Always the caveat is that as social workers, we can make assessments. We can never say conclusive that, the antidepressant is doing the job, but we can definitely say antidepressant appears to be making a difference in the person's behavior. And I think that that's sometimes part of what's missing. We do our evaluations. Is anyone taking a look at the use of the medicine that has been approached? And often I find it's us, the social worker, that's remembering to look at that and to ask, do we need to drop it, and get a consultant in there to help us figure out what's going on. But so one approach to care would be for us to provide the services directly. And I think if we're dealing with some milder conditions, as I've said, such as adjustment to moving facility or loss of independence, those things I think very confidently we can do as part of the team in the nursing facility that would allow us to do that. Now, the other approach or additional approach, because we can provide in-house as well as prefer out, is to refer the resident to outside resources for care. For more severe mental disorders, perhaps we can make a referral to an outside mental health professional. That could be a clinical social worker, clinical psychologist, psychiatry, or a licensed counselor. I see if you refer out that the social worker, that you are the bridge between nursing home and the outside professional, and that you are familiar with the action plan of the professional. What I've noticed times is that when we get the referral outside, we tend to no longer follow up or maintain a contact with that outside referral and lose touch of what that person's plan is for our resident. And I think as social workers, we are responsible for knowing what's going with psychosocial needs and how they're being addressed with our residents so that we can answer if anyone should ever ask us, particularly if we're sitting in a plan meeting or when our infinite visits from the surveyors come by and visit with us. So two is direct or by referral. So the social worker, we complete assigned parts of the MDs, and ideally we work with the MDS nurse if mood or behavior is triggered. And I know that across the nation there's different pieces of the MDS that social workers do complete, but for the most part we tend to do Section D, the BIMS, Section D, the mood, and then Section C, the delirium. So those tend to be the discharge plan, which I believe is Q. And we sometimes do as well. But so I'm aware of the fact that it is around the country. But what we do, what we work with the MDS nurse, after we complete the MDS and are triggered, oftentimes what happens is that there's a computer-generated software care plan that's put out. As social workers, I believe that we need to ensure the computer-generated software care plan is accurate, it's realistic, and it's measurable. And I say this because there have been care plans that I've seen generated that has the social worker visiting a resident 4 times a week for work to listen to their concerns, and I had 160 students as on my load. There was no way I was going to be able to do 4 one-hour visits with just one person. So I encourage social workers, once you complete the MDS and then you just kind of turn it over to the MDS nurse and you never look at what's on the care plan, that I strongly encourage that you do that. I've been talking to some social workers around this area, Fort Worth, Texas, and oftentimes the MDS nurse will say thank you very much to the social worker and not make any changes. So that's a little disconcerting to me. So I'll put here on the slide that as I've become concerned lately, that social workers have little, if any, role in the development of the care plan as it relates to social work services. So I just this as a barrier or a concern. So are you looking at the care plan? Does the care plan reflect what you, the social worker, is doing or capable of doing? And if not, can make a change, can make a correction or an amendment to what's written in the plan. And I hope that would be the case. Again, it's working with the MDS nurse and hopefully making changes as one is possible. I've often heard, well, computer doesn't allow us to do it. Last time I looked, we created computers, so I'm thinking that there must be a way that we can help make the changes so that we can work with how we. So that you've heard my soapbox on plans, but I really think that it is important that we play a very important role in the plan, particularly when something is triggered from social, such as mood or behavior. So once the care plan is implemented, final evaluation is important. Documentation is critical. Grew up with the old saying, and I'm sure y'all remember it, is if it's not documented, then it wasn't done. And sometimes time constraints, it's frustrating to get it all documented, but we do the best we can. Shown on this slide here, it might be a note as simple as the day that you met with the resident, discussed loss associated with sister's death, offered reassurance, the brighter affect, noted this visit, your initials and your credentials could be written on there. So it might be something as simple as that type of documentation. It's important when you do your follow-up that you evaluate if the plan is effective. Is the resident resuming previous activities? Does she care about her personal hygiene? You know, is he talking about his wife's death? What was written in the care plan that you, the social worker, were going to do in order to help reach the goal so that the resident would achieve what it is that they needed to achieve that was documented in the care plan. I've kind of mentioned this already, but, you know, if medication was prescribed, I encourage working with the nursing staff and the family or significant others to assess effectiveness of the medication. Even though, as I've said, not qualified to prescribe meds, we can certainly observe behavior change, whether it's good, bad, or ugly. Finally, though I've written it on this slide, if the plan isn't working, what needs to be made to help bring about change? So part of what we do, we go, we implement, we assess, we plan, we implement, and we evaluate. Put some resources in here because I think this is really important. There's a lot of great resources out on the web. It's sometimes knowing which resources are really good and where should turn to look. So I put the first resource is our NHSW standards for social work and long-term care. I was getting my policy and procedure book for one of my facilities. I used standard to help me develop my policies and help to explain to the administrator why I was doing what I was doing using national standards as the guide. So if you haven't looked at the National Council on Aging Center for Aging, there are behavioral health resources and tools there you might find helpful as well. So it has an excellent tool that you can download and then use in your facility. It's called Promoting Emotional Health and Preventing Suicide. There is a toolkit for senior living communities, and that's senior living communities from nursing facilities to retail communities, just with some adaptation. The MacArthur Foundation Initiative on Depression and Primary Care, it's a toolkit. This was intended to help primary care physicians, primarily doctors, to recognize and manage depression. Why I like this tool is because we social workers often have to talk to other staff members in the facility about what is normal behavior, what is normal mental health, and normal isn't quite the ideal word to use, but what's usual, what's acceptable mental health behavior, and what does depression look like? What does this problem look like that we're looking at? So I like this toolkit because it gives you information that you can use to help educate other staff on your team. So it takes a look at recognizing and diagnosing depression. Again, though, unless you're a clinical social worker, you cannot diagnose depression, but you certainly can recognize depressive symptoms and pass that on to the powers that can make the diagnosis and that can prescribe the treatment. It educates the patient or the residents about depression, and I think most importantly, educate the family, because I think oftentimes the family, just like some of our docs and some of our friends, buy into the idea it's okay to be old and depressed because what else do I have to look forward to? So we get to address myths that I just shared with you. It talks about treatment preferences, about engaging the participant in the doctor and how to explain the process of care. And I think this is important because it's important that all team players be on the same wavelength when we're with individuals with depression or mental illness that we're trying to in the nursing facility. Finally, in this MacArthur kit, there are some evidence-based guidelines and management tools for treating depression, and then monitoring the patient's the residents respond to treatment. So I think that's an ideal toolkit that I would urge you to look at and adapt as you may need it in your nursing facilities. Handy-dandy resource to increase your knowledge is what practitioners should know about working with older adults. Even it comes from psychology. It is a very helpful guide, and I would encourage people to read that. And something else from the APA is the Caregiver Briefcase. It's got a wealth of knowledge and information in there that you can add to your social work toolkit as you work with your residents and the family members in the nursing facility and help add to your knowledge, as I've said, about helping improve the mental health qualities of our residents. I have spoken rather fast. That's because I'm a Yankee living in Texas, but there is about 20 minutes left in the presentation time, so we can either open it up for questions if there are questions, or if not, I have a couple more things that I can add to the presentation. We're not necessarily on the slide. So, Mercedes, I'm going to leave it up. Do we have any questions?
Okay. First, a wonderful presentation and overview. Thank you so much. That was very helpful. I'm looking to see if anybody has raised their hand, and I don't see any hands raised of people who have called in. So if those of you who are on the computer would like to type in a question, go ahead. We'll take a few minutes. All right. The one question is, what is the call-in number? That was provided up there. So if you put it in the chat box, pardon?
Do you want me to put the board up again?
Oh, that's right. Thank you, Pat.
Yeah.
So this is the call-in number. If anybody does have a question that they want to actually speak in, just hear your voice, go ahead and call this number and then raise your hand, and we'll be able to do it. Otherwise, I'm going to keep checking the chat box, the questions there, or the question and answer box. There are no new questions there.
Okay.
So people feel they could be typing, there is a question in the chat box. Can you repeat the Medicare reimbursements for 2013 and 2014? That's the question.
Yeah. Let me look at my notes on that one. Yeah, and in fact, if you want to, you can go to the Medicare website, and you will be able to find this if you need hard copy to show somebody. But as of 2014, Medicare is going to do the 80-20 split for mental health services, just like they currently do for medical care services. Currently, in 2013, the split is 65-35. And remember, it's 65% of the allowable amount. Remember, Medicare sticks the word in there. So it's 65% of the approved amount, and then the individual is responsible for 35%. But next year, that changes to 80-20.
A question right now. Those of you who are on the phone, please raise your hand if you would be interested in a separate session just about the changes in Medicare payment for mental health services in 2014, because we could arrange a special webinar session about Medicare changes for mental health reimbursement in 2014. So if you're at all interested in that, would you put up your hand, raise your hand cyberly, so we have a sense if this is something that folks are interested in. Okay, and we've got people who have presented who would be interested in something like that.
Great.
All right, and just a little commercial. Anytime there's a topic that you would really like to see addressed, shoot an email, and I'll see if I can find people to present it, because if you're interested in it, others will be too. All right, so what we heard from Pat loud and clear is that there have been some changes in the Medicare reimbursement for 2013 and bigger changes coming up in 2014. The conditions under which Medicare will pay, it used to, you had to have be under a physician's order for mental services.
For clinical social workers, that's changed. So that's a good thing. And more and more we're advocating for ourselves that that person can get therapy services without having a physician's prescription, or physician's order. So that's really good. There are some exciting changes that have been happening in Medicare and mental health, so I think that would be a great webinar to have.
Okay.
Because even, in the nursing homes, I know some of us get teams of people that come in, different services that come in and provide mental health services to our residents in the facility. So I think it's helpful for us social workers to know how is this company billing and how it's expected of my resident / caregiver to pay if the resident's not able to pay for it. And I know, like, we've got Medicare, Medicaid, and that takes care of it. But if you're Medicare supplement, what does that mean to pocket costs for our residents? So I think that's important for us to know. So,
good point. I'll arrange a webinar topic. I want to just point out that our speaker has mentioned quite a few times, and I'm glad she did, the effects of advocacy. Social workers have been advocating for change that increase access to services, and those over time things are improving. We have a few other questions. There's another question. What has been your experience with our few, if any, mental health resources, particularly for Jerry Psych? What do if there aren't that many mental health resources?
We, unfortunately, that's the case here in Texas. We're pretty big, and we got rural communities that don't have a city, but for 2 or 3 hours away. We've tried to at least have, like, through our agencies aging in these communities, who can they contact? We try to put it on like the 211 or 411 that you call in and you get information. Not typically, but we're starting to see telemedicine happening now with people in rural areas that can't get face-to-face with a clinical social worker or a clinical psychologist or psychiatrist. This is coming out of some of our medical schools and reaching out to rural areas. So I think we're starting to use modern technology. However, I'm just getting ready to do a presentation next week on the ethics of this. What do we lose when we switch to modern technology? But the thing that at least the person is getting some assessment, and then there is some recommendation going on. And it's always good to have it in your pocket, in your toolkit, some of these tools that I've shared with you on the webinar. But yes, it's frustrating. I will tell you that. You as a social worker in the nursing facility, you do the best you can. Oftentimes it becomes behavioral intervention rather than in-depth psychotherapy, perhaps from a clinician.
Sort of a related follow-up question to that, Pat, is another question that says, do you have or do you know of any standards related to the PHQ-9 total severity score that would indicate at what point you make a referral to an outside mental health professional? Or so when do you decide, based on the PHQ-9 results, when you decide time to make a referral to a mental health professional?
That's a good question, because I remind people these paper and pencils are simply that, paper and pencil, and they're a screening tool. They don't make diagnoses. So is there a number, like would I say at 13 out of 15 on the BIMS, okay, it's time to make a referral, or on the PHQ-9, they score the highest possible amount. Is it time, should I make a referral at that point? I say don't use the number. First off, there are no standards that say if you score 12, make an outside referral. There is nothing like that exists that I'm aware of. So you do your clinical or your eyes-on assessment. So gather all your data. And then at that point, if you say, okay, this is something maybe I can tackle in a nursing facility with the staff and the resources I have, then you do it in-house. If you look and you say, oh my gosh, there is no way I can do this, we need to really call in some big guns. I'm going to call in people from the community or make a referral to the people in the community, then that's what you do. So the professional social worker, this is part of your assessment, of your implementation decision. Does that make sense?
Yes. Yeah.
Okay.
And also, I would add to that, it may be that each nursing home needs to decide what they're going to be doing. You know, what kind of protocols you're going to want. And the social workers should be completely part of that. There's another question related to that, too, is, you know, how do you assess at what level the PHQ-9 do you suggest an antidepressant to the physician? But I heard you really loud and clear, Pat, when you said that that's a screening tool. It's not a diagnostic tool. I would think that the social worker then would alert the physician that the screening tool indicates evidence that this person needs to be further assessed for depression.
Right, yes.
Yeah.
And I think it's very important that as a social worker, if you can, you create a very good relationship with the medical director of your facility. I think it's good that we as social workers have a working relationship with all of our docs that come in, if that's possible, because when doctors come to our facility, they look at charts, they look at the people, and then they leave, and they're usually there once a month. They need to hear information from us, and so they need to believe in our credibility. So if I walk up to a doc and say, this tool, PHQ-9, this is the score out of this, these are the clinical symptoms I've seen, and I think that this, you know, I'm thinking we should talk maybe about an antidepressant, that the doctor then is going to say, okay, social worker, I'm listening to you, something along that line. So I think that's important to have that relationship if you can, and so to be knowledgeable of antidepressants. We don't order them, but we sure do want to know the names and what types they are. And there are books out there for social workers about antidepressants and psychotropic medications.
There's another question that says, can you speak more to the high percentage of individuals in nursing facilities who have a primary diagnosis of mental illness? Some where it says 70 to 80%, this seems really high. Are you including other diagnoses in the mental illness category?
Right. I'm including, again, this study that I quoted from. I can't remember if on the slide I said that it did not include dementia, but I wanted to say the 70 to 80 that I remember looking at was saying that this was including dementia as a diagnosis, but the other study that was done by MDS was did not include dementia.
Okay.
Oh, I'm sorry. Let me correct. I'm confusing myself here. Yes, this was a study, and I want to say it came out of the East Coast area. Is 70 to 80% of people living in nursing homes had mental illness as a primary diagnosis. Now, that one did include dementia as a mental health diagnosis, and we know now dementia is not a mental health diagnosis. It is a medical condition. That study there, the 70 to 80, included people with dementia.
Okay. So whenever you look at these studies, it depends on was it based on one nursing home, was it based on one region, one state, or national representative? Because there's a lot of variation, as everyone on this call knows, a lot of variation in studies and care needs of people in specific nursing homes.
I can walk in one facility over here in Fort Worth, and I will tell you that 90% of them have a psychiatric diagnosis as their primary diagnosis. They go down the street, and you might only find 40% or 10% or something. So it varies from home to home, state to state, and region to region. So
I think the other thing to bear in mind is some of the studies report sectional data, so as of one particular day of the year, and other people are going to look at during the course of a nursing home stay how many residents develop a mental health issue, and so those are different things too. But either way, it's prevalent. It's very prevalent for people to have mental health challenges in nursing homes.
And that's really one of the reasons why they move into a facility for that reason, that it does have impact on their physical functioning.
Yes. I see another question here, or did you have something you wanted to say, Pat?
No, I was going to say I see that question too, and that's, okay. I hate that question on the PHQ-9. Is that one you're talking about, the safety notification?
No, go ahead and read it in case other folks can't see it.
Okay. What do you feel is a safety notification for individuals who answer yes to, and this question is on the PHQ-9 in case you want to know, do you, yes to thoughts that you would be better off dead or hurting yourself in some way? First off, I think that no one who created the PHQ-9 asked me, but I really think that these are two questions within one, and it creates a problem for us because we take a look at thoughts that you would be better off dead. How many of us encounter residents and older adults who say, you know what, this is just getting to be too much, I'd be better off dead. Then that doesn't mean that they're going to hurt themselves or kill themselves or harm themselves in some way. And yet this question is asking us yes or no. So what I have done with this question is I treat it as an or. Like it says here, thoughts that you would be better off dead or of hurting yourself in some way. A person says to me, I would be better off dead. I use my social work skills, and I explore what it is that they're saying. Now, if it goes on and they say, I'm saving up all of my medicines and I'm going to swallow them, I'm going to hurt myself, to me, there is true lethality in that plan, and there has to be what we call safety notification. And that would be to inform the staff, to inform the resident that you're going to inform the staff that that won't allow people to kill themselves here in the nursing home setting. So, if they do answer yes, and there is indeed lethality, intent, and a plan, then I think a safety notification is in place. So you've heard me say it's not just answer yes isn't enough to me, because I do run across people who say yes to the first part, but heck no to the second part. And so I think we have to, as a clinician, explore that, as a social worker, explore that further and see what the depth of that is. I answered your question. I certainly went off on a soapbox on that, but I do. If they do answer yes, and there isn't that lethality, and there is intent, and it could possibly happen in your facility, then a safety notification should be made.
Right. We have about a minute and a half left. We did not address the question about hoarding, and I'm not sure we're going to have time to address that today, but that's another good topic. I do have a couple announcements I wanted to make before we go off the air. First of all, we do have our April webinar. It's going to be delivered by Cindy Mason from Project Paradigm, and she's going to be talking about the important tools to enhance nursing home care planning and survey results using critical elements of care developed for the Quality Indicator Survey, the QIS survey process. So more information about that on our website, including the background for Cindy Mason. I also wanted to mention that the case that you gave today, Pat, was really compelling, showing what a difference a social worker can make. And I'd like to remind all our listeners that if you have a case that is related to end-of-life care, the Journal of Social Work in End-of-Life Care publishes pieces and reflection pieces as short as 7 lines and as long as 7 pages that talk about social works reflecting on their role working with persons approaching the end of life. So I'll put something about that up on our website as well. But those of you, by sharing your cases, it's a wonderful way to help other people learn about what social workers do and help prepare students for this very, very important role. I cannot thank you enough for a very exciting and interesting and insightful presentation today and giving us a lot of information and also a sense of how you function as a social work consultant. I think that could be another webinar topic, is one just on social work consultancy.
Well, thank you. I appreciate it, and I just want to extend if there's anyone with questions, my email address is on that first slide. So please feel free to drop me an email, and I'll be glad to answer your question.
Thank you. And also, we do have the listserv that people can put questions out to each other as well. Thank you so much for your time and attention, and we hope to see you next month. Bye. Thank you.
You know that hoarding one?